for me, send me radiological images. It's so easy to communicate and have the patients taken care of in a setting which is away from the hospital, at home with family, which is obviously better for them and extremely easy for me.
Terrific.
I don't know if I have a whole lot to add to that. I think it's just, they get back into, their hometown. They're able to be in their own home. They're able to do the things they want to do. And I think that in and of itself just accelerates recovery, and you start to feel more like a normal person again. I think, we have such a line of communication that if I have a problem, I know who I can pick up the phone and get a hold of and discuss that problem with. We do share information. Technology-wise allows us to do that. We share information electronically, like the scans and everything. Our lab in our office is set up to, when that report comes out to my desk, it's already been faxed to Dr. Botha or to Dr. Fitzke if it's a preoperative type of situation. We do use technology and to help keep everybody on the same page. And so I think when a patient can get back to their primary care physician who can kind of be watching everything, and we go into this assuming we're just talking about carcinoid, but we may have hypertension, we may have depression, other things that we deal more with, and so we know what those issues are, and we can take care of them and work collaboratively together on the problems, the post-operative complications, whether that's a pleural effusion or whether that's a wound infection. We can talk back and forth, and if we save them a trip, coming back up to the tertiary care center, then that's just even better for their care. But if we need them to come up, we make those decisions, and so it works well.
Terrific. And Dr. Fitzke, let's talk about your role in Ruth's surgery and your role in this kind of surgery generally.
As a general surgeon, we're faced with obviously situations like Ruth, not infrequently, and most of them don't turn out to be carcinoids. Part of it is you just have to have a high index of suspicion. When somebody as thorough as Dr. Zaruba calls you and says, this is what's going on, you need to open your ears, you need to listen, you need to realize what you need to do and when you need to do it. And that was kind of what we did with Ruth. We got Ruth up, we talked about what this could be. Quite honestly, I was not expecting it to be a carcinoid. I thought this might be a lymphoma or something along those lines. We approached it with the idea that we would, and as any general surgeon should, you approach something that you realize you can handle, and you leave the things that you can't handle to those with skills to do so. And that's what we did with Ruth. We simply we resected the area of small intestine mesentery that was involved with a gross tumor. We biopsied the spots that we could see in the liver, knowing that I didn't have the expertise or the ability to resect those areas. But we could confirm exactly what they were so that somebody with Dr. Botha's expertise could take it the next step and realize exactly what it is that he needed to do. So.
And what did you think when you received Dr. Zaruba's call?
It was simply one of those situations where Dr. Zaruba was entrusting me with the care of one of his patients, and I simply hoped that I could provide whatever care that was necessary for Ruth. So.
And I want to jump in here because I think this is a very important point that needs to be made for carcinoid patients. Dr. Fitzke is the whole key to making this work. Had he gone in and done things that, as he said, maybe was outside of his skill set, or had attempted to, I'm going to do everything I can for this patient, but maybe it wasn't, it could have severely inhibited Dr. Botha's ability to do anything. And I think that communication that he had beforehand, his skills as a surgeon, is what allowed us to get to the next step, which is to be a candidate for what Dr. Botha can do. And I think that's a lesson, unfortunately, in another carcinoid patient that I'm taking care of now, the surgeon didn't do that, and did some things that maybe we wished wouldn't have been done. And I think that's very important for a carcinoid patient when you go to your general surgeon, for your primary care physician to communicate with them, to have good general surgeons that can understand the process of what needs to be done and what doesn't need to be done. Sometimes that's more important, and that's just the key to Ruth getting to the next step. And so even though Dr. Fitzke will downplay it, I think that was an extremely important decision. That decision was made in the OR, while he's, doing the surgery, that gave rise to the ability of Dr. Botha to come in and do the resection.
And Dr. Fitzke, what made you decide to go that route of the biopsy and not attack it further?
The areas on the liver and on a CAT scan, although were plentiful, they were relatively small. We knew we wanted tissue from those areas to prove exactly what it was. Again, sort of anticipating that it was something less rare and potentially something more commonly seen, such as a lymphoma. My radiologic colleagues thought that they were too small to be able to reach adequately, and we knew that we had to go in and resect the area of disease near the intestine because that was obviously potentially a hindrance to her gastrointestinal function. So we simply opted to start laparoscopically, be able to visualize the liver better, and simply being able to identify one particular location where the lesions were present, biopsy it so that we'd have that information, and then go ahead and tackle the bulk of the main tumor. That's a discussion that I had with Dr. Zaruba and Ruth, and that worked out very well for us.
Terrific. And how many procedures have you done on carcinoid and related neuroendocrine tumor patients?
Well, thanks to Dr. Zaruba. More than I had prior to our interaction. Shortly after Ruth came another patient from the exact same vicinity with a very similar type presentation, only at least on CAT scan, did not have any evidence of liver disease, and as it turns out, that's what we found out at the time of operation as well. You simply have to approach these with oncologic principles of being able to remove all tumor that you possibly can in hopes of gaining clear margins without hindering the potential for other therapies to potentially work as well. And basically, what I've really learned is having a high index of suspicion. Again, carcinoid was certainly on the list as we went into Ruth's case, but it was quite a ways down the list simply because we just don't see them that very frequently. And so having a high index of suspicion, taking a case like Ruth's and personally learning from it, and then the collaboration that the three of us had, knowing exactly what we could do for each patient afterwards, has been very important to my education as well as my practice.
Terrific. And I'd like to touch on that issue that you brought up of the additional carcinoid patients that you've seen as a result of Dr. Zaruba. Dr. Zaruba, it sounds like in your area there have been many carcinoid cancer patients diagnosed, more than you would expect for that area. Can you describe to us a little bit more about when you first saw your first carcinoid cancer patient? Was Ruth your first, and then how?
Actually, Ruth was not my first patient. I had seen a couple carcinoid patients in residency, although had not made the diagnosis myself. They had been, they'd come to me after being diagnosed. So I had a little bit of knowledge, but not, and I still don't consider myself an expert. But I've seen, since then, I've personally made the diagnosis in at least 3 cases, and we have approximately 6 cases in this small community where we live, and certainly that's concerning. That's a little bit unusual, and there may be some link there may not. But what I've learned though is if you don't think about carcinoid, you'll never make the diagnosis, and that's where the high index of suspicion comes in. And the diagnosis with Ruth was extremely difficult because of some things that had transpired prior to her actually coming in for the workup. But we thought about it. It was in the differential. We made the diagnosis, and I think physicians just have to have a high index of suspicion. They have to think about carcinoid, or they'll never make that diagnosis. And I think you have to convey that to your surgeons. You have to have a surgeon that'll listen. I mean, I could have called up a surgeon who'd tell me I was crazy. You never see carcinoid. What are you talking about? It's that rare. Dr. Fitzke listened to me. And we both honestly thought it was going to be lymphoma. I thought that, but it was on our differential, and we did the things that we needed to do, getting her ready for surgery. He did the right surgery. Everything then set up for Dr. Botha to come in.